Hi, this is Elliot Fishman, and welcome to our latest podcast. This is going to be a two-parter. It's going to be on great mimickers of pancreatic cancer, mistakes to avoid. And we know that many cases of pancreatic masses are very straightforward. It's pancreatic cancer. But there are other cases where it may be other tumor types, including neuroendocrine tumor. It may be something arising from the duodenum, like a carcinoid or a GIST tumor. It could be things like an annular pancreas. There are many possibilities, and I'm not going to go into them in great depth. That would probably take about a 6 or 7 part lecture. This is going to be a two-parter. We're going to cover some interesting things. I always like this quote: people trust their eyes above all else, but most people see what they wish they see or what they believe they should see, not what is really there. That's an important quote for radiology. What's really there, not what you think is there when you look quickly. And again, it's sometimes very difficult. Okay, pancreatic cancer. We talk about smaller lesions. This case, good example, arterial phase. Dilated pancreatic duct with transition right in the body of the pancreas. You can see it here again as we go to the venous phase. Duct dilatation, abrupt cutoff, low density mass in the 2 centimeter range, a few tiny nodes nearby. Here it is in the coronal view. Again, dilated pancreatic duct. Patient has IPMNs as well, as is pancreatic cancer. Very classic adenocarcinoma. And here it is again on the cinematic rendering. We speak about how cinematic rendering is really good at looking at the duct, but also picking up subtle tumors. In this case, the routine scans and the cinematic both nicely showed the patient's pancreatic adenocarcinoma. Nothing very difficult, okay? Straightforward. Another case, there's a soft tissue mass in the junction of body tail of pancreas. The gland is atrophic distally. We'll look at it a little bit more carefully. Coronal views, or this sort of oblique right through the center of the gland along the pancreatic duct, shows things very nicely. There's a tumor. It's not neuroendocrine. It's an adenocarcinoma of the pancreas. You can see it here on the cinematic rendering as well. So those are two cases of relatively small tumors, but very, very obvious tumors. Now, when we talk about pitfalls, lesion detection and identification. Everything is finding the lesion or a lesion. But again, as we mentioned, there are some anatomic variants which can be somewhat tricky. You could talk about lesions in the tail of the pancreas and maybe think about an accessory spleen. More commonly than an adenocarcinoma, it simulates a neuroendocrine tumor. We could talk about mimics of adenocarcinoma, autoimmune pancreatitis, which can involve the entire gland or be focal, and the history is often weight loss, elevated CA19-9. Everything about the clinical history can match pancreatic cancer, but it's autoimmune pancreatitis. We talk about groove pancreatitis, which has mass effect on the duodenum and can look very similar to a tumor. We talk about peripancreatic masses, whether it's something in the duodenum or it's a neuroendocrine tumor in the groove between the pancreas and the small bowel. We talk about lymphoma as possibilities. And again, neuroendocrine tumors, they're usually hypervascular, probably 80+% are hypervascular. But when they're hypovascular, they can really simulate a pancreatic cancer. In terms of duct dilatation, neuroendocrine tumors can be centrally in the gland, in the duct proper, or simply be near the duct. So you don't always have duct dilatation, but it can be somewhat challenging. We mentioned about duodenal lesions. Carcinoid and GIST can both be vascular, and then it's sometimes hard to tell them apart because things that are helpful, we typically don't see a dilated common duct, we don't see a dilated pancreatic duct, but particularly like GIST tumors, which are exophytic, the question sometimes is this lesion pushing on the pancreas or is it part of the pancreas? We talk about serous cystadenoma. When they're large and cystic, it's not a difficulty, but there's a variant. About 5% of cases have what looks like a solid mass that's hypervascular. Looks like a neuroendocrine tumor. Can be somewhat challenging. Sometimes it's not that vascular, but can look like an adenocarcinoma. So again, there are these pitfalls that we're aware of. Now, in terms of technique, dual phase imaging is ideal for looking at the pancreas. We want to do arterial and venous phase imaging. Typically arterial about 30 to 35 seconds. Venous probably closer to 70 seconds. We want to distend the stomach and proximal bowel, so we use water as the agent of choice. People used to use volumen, but water is what you want to use. About 1,000 cc's in split doses, about 750, 15 to 30 minutes before, and the last 250 at the time of the study. And of course, we're using IV contrast. We're injecting ideally at 5 cc's a second. In the arterial phase, what's the big things we find helpful? Well, things that are vascular, like neuroendocrine tumors, may only be vascular early. Interestingly, adenocarcinoma of the pancreas, we typically see it in both phases, but it may be a bit more obvious on the venous phase. And when you look at AI, everyone looks at venous and not arterial. We also talk about metastasis to the pancreas from, let's say, a kidney renal cell carcinoma. They're typically hypervascular, but don't need to be. And we mentioned that some adenocarcinomas, the majority are best seen on venous phase imaging, though some may be better seen on arterial phase. People have also written articles that sometimes small tumors are better seen on delayed phase. And when they say delayed phase, they mean 8 to 10 minutes. We don't do delayed phase imaging on the pancreas. We do not find it helpful. Of course, arterial phase is also important in terms of vascular mapping, the celiac, the SMA, hepatic artery, any anatomic variants, things that would be important to the surgeon at time of surgery. Venous phase imaging, the majority of adenocarcinomas are most conspicuous, which is why all the AI tends to be on the venous phase. It's also ideal for metastasis. It's typically easier to see liver mets on venous phase than arterial phase. It's also the phase for portal vein and SMV involvement, narrowing, thrombus or collateralization, and also gives us a look at the other organs besides the liver, the kidneys, the spleen, and everything else you would want to look at. Now, one of the things, of course, is when you have imaging that's late venous, it can be challenging. If you look at this case, maybe you see the suggestion that the pancreatic duct is a little prominent. It's kind of minimal, but you don't really see a mass. But if I would have given you that area in arterial phase, look how obvious the lesion is. That's a greater than 2 centimeter mass, but it's obvious on arterial phase and washes out on venous phase. That becomes very, very important. We talk about neuroendocrine tumors. If you don't do arterial phase imaging, you're going to miss a lot of the lesions. No, you're not going to miss a 6 centimeter mass, but you're going to miss a 2 centimeter mass. And this case is just a really nice example showing you the problems involved and the potential pitfalls. Here's another example. Cystic lesion, you could say, could it be a pseudocyst, IPMN, MCN, serous cystadenoma? You notice rim calcification, which still is not that helpful in and of itself, but you notice also there's rim enhancement. So now you give me, and I accentuate it a bit, you give me a cystic lesion, body of pancreas, rim calcification, and peripheral enhancement. I'm going with a neuroendocrine tumor. Adenocarcinomas typically are in cystic. You can talk about cystic acinar cell tumors, perhaps. You can talk about sometimes adenocarcinomas become necrotic, but they don't have really good rim calcification. You typically don't see calcifications in adenocarcinoma, and you surely don't have this enhancement pattern, which is very good for a neuroendocrine tumor. Here it is on the sagittal views as well. So enhancement and where the enhancement occurs becomes very, very critical for us. And again, here's the 3D volume rendering in that patient, very nicely showing you what ends up being a cystic neuroendocrine tumor. So again, we look at calcifications. Adenocarcinoma does not calcify typically. You can see calcifications if an adenocarcinoma arose in a patient with chronic pancreatitis. When you see calcifications, you think about, based on distribution, neuroendocrine tumors. You might think about a serous cystadenoma, particularly with central stellate calcifications. You could talk about MCNs with peripheral calcifications, or SPEN tumors, which can have dystrophic calcifications as well. Now, when we talk about congenital anomalies and variants of the pancreas, they at times can simulate pathology, so you really want to be careful understanding how the pancreas looks and looking at enhancement. Now, in terms of tumors, I mentioned a few of them. Here's a large mass, but has lots of calcification centrally and peripherally. The lesion is cystic. There's no dilated intrahepatic ducts. If this was an adenocarcinoma, which rarely is detected at this size, usually it's detected early, those lesions also would have dilated ducts. Serous cystadenomas typically do not. They typically have calcifications, as we see in this case. And you can see when you do the MIP imaging, the extensive calcifications throughout the gland or through most of the gland. You also see stretching of the GDA. That's one of the signs of serous cystadenomas. So a very easy diagnosis. I don't think you're going to confuse this one with a pancreatic adenocarcinoma. And here's the same case with cinematic rendering. Again, very nicely showing you the calcifications, showing you the cystic components, and showing you the lack of duct dilatation, either pancreatic duct or common duct. Now, in the congenital anomalies, things like annular pancreas can be somewhat challenging if you don't think about them. We talk about ectopic pancreas, but those are going to be less common. I think annular pancreas is the one at least you'll see in conference, or you'll see every once in a while in practice, and it is a great pitfall. A segment of the pancreas surrounds the second portion of the duodenum. That's what an annular pancreas is, right? Instead of staying medially, it goes over and beyond to the other side of the duodenum. And it can be confused with a pancreatic mass. There's two types people talk about, extramural and intramural. Extramural presents with duodenal obstruction, while intramural presents with duodenal ulcerations. And the extramural is the one we typically are thinking about. Here's a nice example. You see the pancreas looks good, no dilated duct, but then you see this mass here. What is this? Well, this is the classic annular pancreas. You could see it could simulate a duodenal mass. You could think about duodenal mass. You could think about an implant there. You probably wouldn't think about pancreas, though you could in your mind think about ectopic pancreas, but that's intraluminal. This is around and pushing on the duodenum, but that's a classic appearance for an annular pancreas. It's a leave-alone lesion. Here's another set of images of that. You can see how the pancreas goes around the duodenum surrounded, and annular pancreases can become symptomatic because the patients can have abdominal pain. So a nice example. Now, of course, when we mention duodenum, annular pancreas we talk about duodenal primary tumors, such as a duodenal adenocarcinoma. Here's a large ulcerating mass, which could simulate a pancreatic adenocarcinoma directly invading the duodenum. One thing often helpful with duodenal tumors, you typically do not have common duct or pancreatic duct dilatation. Now, other mimics of pancreatic cancer, we talk about the texture of the gland, fatty infiltration. Maybe it's low density. How do you know it's fatty infiltration? Can be somewhat challenging. We talk about autoimmune pancreatitis. We talk about groove pancreatitis. We talk about other tumors, lymphoma, peripancreatic adenopathy, and primary duodenal tumors, like we mentioned, perhaps an adenocarcinoma or a GIST tumor or a neuroendocrine tumor. Now, fatty infiltration of the pancreas is not uncommon, but more common in patients who are diabetic. It can be focal or it can be diffuse. You typically do not see duct dilatation. We like to think that posterior aspect of the head and uncinate are usually spared, but again, it can simulate a tumor. There's no mass effect and there's no duct dilatation. It's usually apparent on CT, but at times MR can even be more helpful if you're not certain. And here's just a good example of fatty infiltration of the pancreatic head, where you can see, when you look quickly, you could say, well, how do I know that's not really a tumor? So you want to look very carefully at fatty infiltration, a very important diagnosis. Now, another diagnosis is autoimmune pancreatitis. We see this now. We see a lot of Ig4-related disease. Often it's diffusely enlarged. The gland is cigar-shaped. We talk about the halo around the gland, best seen on the lower images. We also know with autoimmune pancreatitis, you typically do not see common duct or pancreatic duct dilatation. Patients with autoimmune pancreatitis are treated with steroids for about 2 weeks, and the patients will do fine. With autoimmune pancreatitis, you can have duct stricture, so you can see common duct stricture. So again, the diagnosis can be somewhat challenging. And here's just another example of that halo. Again, the gland is enlarged, it's sausage-shaped. There's the periphery. Sometimes you'll see duct thickening, autoimmune involvement of the common duct. Sometimes you'll see changes in the kidney as well. So it can be somewhat of a difficult diagnosis. And again, clinically, we see them at times at multidisciplinary conference. Patient has weight loss, abdominal pain, CA19-9 is elevated, and then you see a mass or mass-like process in the pancreas. So everyone's thinking about cancer. Maybe the biopsy is negative at first, but that happens. So it's a very, very important diagnosis. Now, the next thing we'll speak about is groove pancreatitis. But I think we'll do is let's take a break. We'll come back with groove pancreatitis and some of its features and finish up part 2 of this talk. So let's take a 10-minute break, and I'll see you then. Bye, guys. If you like this video, make sure to subscribe to the CTisus YouTube channel. You can also visit us at ctisus.com for even more videos, plus quizzes, pearls, protocols, and oh so much more. We're also in the App Store and have well over a dozen apps for iPhone and iPad, all completely free. Thanks for watching.